and hopefully it will be interactive. Some of the cases are harder and some are easier. We'll just go along with the cases. So case number 1, the questions will be, what study was performed, and what is the diagnosis? There are 2 images here. On the left is a T2 fat suppression, and on the right is a T1 fat suppression. For the residents in the audience, what study was performed? What kind of MRI? Who votes for an MRI of the shoulder? Who votes for MR orthogram? Orthogram? Hey, no, there's another no in the audience. He's a male. Okay, so this is an MR orthogram, and you can see it by two findings. Let's say 2 imaging findings. One is that there is some joint distension, and as you can see in the T1 fat suppression, it's bright. So when would one use the T1 fat suppression? Basically only when there is something going on with gadolinium, either IV or intraarticular. In this case, you see the joint distension, you see a relatively high concentration of gadolinium in the joint, and that's direct MR orthogram. So what you can see here is a coronal image. This is the supraspinatus, and that's the rotator cuff tendon. That's the tendon. There's high signal in the footprint of the tendon at the insertion on the humeral head. So you can see it here on this T2 fat suppression. You can see it on the T1 fat suppression. Would you call this an articular sided tear? Would you call this just a tear that has no connection to the joint? Or would you call it tendinosis? Who votes for articular sided tear? Who votes for interstitial tear that is not connected to the joint? And who votes for tendinosis? Okay, so this is a case of tendinosis. There's no tear here. Why? First of all, you can see that on the T2 fat suppression, there is high signal in the tendon, but it's not as high as the fluid signal in the joint. It means it's not fluid signal. It's high signal, but not fluid. So this is consistent with tendinosis and not with a tear, because tear should be high signal, similar to fluid. Also, on the T1 fat set, you can see that the gadolinium signal is brighter. Again, and this signal means there's no gadolinium in it, so it's not an articular sided tear. Okay, case number 2. The questions for the next case are, what are the sequences that are used in this case? What do you think the patient's complaints are? And finally, what is the diagnosis? So here you can see 2 images. One is a coronal. That's a T1. You can definitely say it's a non-fat sac because the fat, the sub-Q fat, and the fat in the bone marrow is bright. And this is a T1 signal. You can see by the signal of the joint. This is an oblique coronal T1 image. And what are the findings here? Well, what are the patient's symptoms? Any idea? Who votes for, let's say, what would be the major complaint? And the more specific complaint. 1 is pain. 2 is limited range of motion. 3 is injury, or pain post-injury. So who votes for 1? Who votes for 2? And who votes for 3? Okay, so the few people that voted for 2. That would be the right answer. And what are the findings here? On this T1 weighted image, you can see the thickening of the anterior inferior joint capsule. On these sagittal images, you can see the rotator cuff interval. This is the coracoid process. This is the humeral head. This is the supraspinatus muscle and the subscap. This area here is the rotator cuff interval. This is the biceps tendon. That's the coracohumeral ligament, and as you can see, it's thickened here. Also, it should be surrounded by pure white fat, bright fat, and you can see that there is some fatty obliteration in this interval. And this is the same image basically, or the same sequence, and you can see the thickening of the capsule. It's at least 6 millimeters, should be not more than 4. On the T2 weighted images, you can also see that the capsule is somewhat bright, and these findings are consistent with adhesive capsulitis. The clinical term for this is frozen shoulder. These patients come with pain and limited range of motion, but everybody comes with pain. They have the limited range of motion as a major complaint. And sometimes there's a primary cause for it, and sometimes this is the only symptomatology. They just develop, one day they develop pain and limited range of motion. On physical exam, it could sometimes look like there's biceps tendinosis, but not exactly, and maybe a superior labral tear, because all these are adjacent, in adjacent anatomical locations. And the MR findings at the acute stage, as seen on this case, you can see again this thickening of the capsule, and in this case there's also really high signal, a real high signal in the capsule and also around the capsule. This is acute adhesive capsulitis. The thickening of the coracohumeral ligament, the obliteration of the fat in the rotator cuff interval are also signs. So again, these are the sagittal, oblique sagittal images of the second case, and you can see this high signal here, but also here at the area of the rotator cuff interval. Third case. Just about adhesive capsulitis. Earlier, like before the signs of the MRI were recognized, that's relatively only in the recent years. The diagnosis was made based on intra-articular injections. These patients would come for arthrograms. We would inject, and if normally you can easily inject 13 cc's and much more in the shoulder, the diagnosis was based on the small capacity of the joint. We couldn't inject more than 7 cc's, and that was the diagnosis. Also the treatment, it was also the treatment because we used to inject in high pressure to make these micro tears in the capsule, which would cause some relief of the symptoms. The natural history was believed to be that it would self-resolution, just spontaneous resolution in 1 year. But now it's known that only 40% of the cases really go through complete resolution of the disease. Third case. Again, what are the patient's symptoms? What is the diagnosis? And how can the patient be treated? As you can see, there are AP radiographs of the lumbar spine and of the lower lumbar spine. And the hint would be that you can see here a normal variant that could cause pain. Let's start with the type. Okay? Anybody has an idea? Okay. So the normal variant, as Natalia said, did I recognize your voice in the dark? Okay. So you can see here that there's a lumbosacral transitional vertebra. We see many of those, right? And probably most of the times they're asymptomatic and you just comment on them and that's all. But in this case, you can see the pseudoarthrosis of this transverse process with the sacrum. And you can see that there's a sclerotic line around it on both sides of the joint. You can see it very well here too. And this suggests that there's pseudoarthrosis there. This could cause pain. So how can you treat these patients? How can you get to the diagnosis that this is really the source of their lower back pain? You can do an injection, right? A local injection. You can inject lidocaine, which would give you the diagnostic effect, because you can see if the patient feels better for the next 2 hours or so. And then the steroid injection, the steroid component, which would make some relief for the symptoms, hopefully. Okay, next case, a 30-year-old. These are the radiographs. Anybody has an idea what the pathology would be in this case? What pathology is in this case? Okay, so the major findings here, you see some calcifications, and you also see this enlargement of the distal end of the bone of the femur, and you can see what else? Advanced osteoarthritis. The patient is 30 years old. So you want to look at the differential diagnosis of early osteoarthritis and large end of bone. Any ideas? Okay, so let's continue to the MRI. These are sagittal images, right? These are sagittal non-fat sac, probably T1 weighted images. And on the left, you can see a very poor quality sequence. Why? Because I just took it out of the localizer. Okay, that's the pre-scan images. That's where the technologist planned the study on. That's the sequence. But why did I still select this one to present to you? Because it has some diagnostic significance. This is a gradient echo sequence. The technologists, they use it, it's fast, and they use it because it's a gradient echo. So sometimes if you have questions in the MRI, which the gradient echo could help, you can go and see, maybe you'll be lucky and you can see it in the localizer. Sometimes it can even save you from calling the patient back to dedicated gradient echo sequences. So the major finding here, in addition to the osteoarthritis, is this very dark signal in the joint. Also some susceptibility artifacts. And with this gradient echo, you can see that it's thicker than in the T1. It means the susceptibility artifact, the so-called maybe metal artifact, is real because whenever you have gas or calcifications or metal which cause susceptibility artifacts, it's going to be much worse on the gradient echo. So sometimes it's bad for us, but many times it's really good for us because it helps us to actually reach the diagnosis of the understanding that there's metal there, or there is gas there, or calcification. So in this case, it really helps me, right, to determine that this is, and there were no calcifications here. This is probably metal. What kind of metal? How did the metal get here? These are blood products, right? There's iron in the blood and in the blood products. So it means this patient had multiple occasions of hemarthrosis, right? And then, because of that, he developed early osteoarthritis at the age of 30. So what would be the diagnosis in this case? Hemophilia. You can again see this is a poor quality study. Look at the susceptibility artifacts here, okay? And this is a case of hemophilia, and the large epiphysis is because he had this increased blood flow to the joint when he was a child. Before or he had like premature growth and premature closure of his epiphysis. Okay, next case. So now we're going to the next set of cases. And I will talk about femoroacetabular impingement. Femoroacetabular impingement is a diagnosis of the last, I think, decade, right? No one was aware of it before, and now it's a big topic. Many people are doing a lot of money on surgeries, and nobody really understands. There's no consensus whether, like, how it happens, why it happens, and how it should be treated. So this is a very typical, and if. So it used to be very much in fashion, and now people are starting to think, have second thoughts about this diagnosis. So in this case, it's an axial, probably an oblique axial image of a hip joint. Orthogram, you can see that it's extension of the joint, and you can see that it's a fat suppression. You can assume it's an orthogram. And there are two findings here, pointed by the arrows. One is this bony bump, anterior, at the junction of the head and neck. And the second one This is the labrum, the articular labrum, which was supposed to be a triangle, black, nice, sharp margins, and you can see that it's thin, and you can see the contrast undercutting the labrum, between the labrum and the acetabulum. So this is the femoroacetabular impingement. There are two types. This type is called CAM. So the major problem in this case is in the femur. It affects usually young patients, athletic patients. We often see it in athletes. We often see it in soccer players. But there's always a question, maybe it's related to the sports, but maybe it's just that we image them more than others because they are, they're professional athletes. And this is a CT image of the same pathology. And again, you can see the problem, the major problem is on the femoral side of the joint. You can see the bony bump, and here you can see the subchondral cysts. They're called synovial herniation pits. These are small herniations of synovium into the bone. Before this topic was in fashion, it was believed to be a normal finding. Synovial herniation pits were called a normal finding. And the name of the person who published it was Pitt, so it was called Pitt's pit. And he made his professorship, I think, on these findings, which are now believed to be pathological. So that's evolution of medicine. Okay, so what's the story about this? So what's impingement? Impingement means that the femur is impinging on the acetabulum and vice versa. So there are two types. The first type is when the problem is, as I mentioned, in the femur. And the second type is when the problem is in the acetabulum. So CAM is the femoral one. So if you are really straight, and in order to reach a diagnosis, you do measurements, and you want to do oblique images, and you want to draw a circle here, and basically you want to mark the center of the circle on the femoral head, and you want to measure angles, as mentioned here in the text, and if the angle is bigger than 55, then it's pathological. I personally don't believe in measurements too much. I think every study that I did myself with measurements, I don't believe my studies as well. So when you get this impression that you have a bony bump here, okay, and you see the changes in the labrum, the changes in the joint, there's symptomatology, then that's the impingement. So now the question is, how does it start? Is it microtrauma? Is it a developmental abnormality of the femoral head that causes this impingement? But the end result is that they tear the labrum and then they develop early osteoarthritis. Again, young, physically active. So we get these patients usually, in their 20s? Unless they come later, and then they come with osteoarthritis. And then there's and another, just one thing to mention again about the CAM type. Some people think maybe it has to do with childhood pathologies, such as slipped capital femoral epiphysis and others. And now let's talk about, let's go fast to the, first of all, before we go to the Pincer type, sometimes if you just read radiographs, you can see these small lesions, loose lesions that can mimic a pathology. They can look like what? Maybe very small, lucent, maybe osteoblastoma, right? But sometimes you can see them as an incidental finding. These are those synovial herniation pits. Okay, again, because it was so commonly seen on radiographs, it was considered to be normal, but it's not. This is a bigger synovial herniation pit, and it looks like, right, like irregularity. Okay, let's talk about the Pincer. The Pincer type is when the problem is in the acetabulum. It's usually older women, and impingement is caused by overcoverage of the femoral head by the acetabulum. So there are several findings or signs related to the Pincer type, the figure of 8, the crossover sign, the posterior wall sign. All these terms are related to the Pincer type. So this is an image that shows you how to measure these signs. So draw a circle in the center of the femoral head, and then you can see the posterior wall of the acetabulum is basically going through the center of the femoral head. Okay? The green line shows you the anterior acetabular wall. Usually, normally, there's some anteroversion of the acetabulum. And this is the figure of 8 sign. As you saw here, these lines are not crossing each other. Each wall could be drawn by a separate line, they're not crossing each other. Now, in this case, you can see that the anterior and posterior acetabular walls are crossing each other, and they form the figure of 8. Also, this is the posterior wall sign, and if this is the center of the femur, the posterior wall is actually medial to the center of the femur, opposed to the crossing. So what's this one? Is this cam or is this pincer? What's the major problem here? Is it over coverage of the acetabulum, by the acetabulum, or is it a bony bump in the femur? So this is the bony bump in the femur, pointed by the black arrow. And what's the result of this problem? You can see here a labral tear and a cartilage defect. Next one. Is this a cam or is this a pincer? So you can see here, definitely, that there is bony, right, over coverage, right? The acetabulum overcovers the femoral head. So what type is it? That's the pincer type. That's the older patients, okay? You can see that there's already, so I lost my arrow, there's already secondary OA here, there are already osteophytes. And this one, last case I think. So here again you can see on these axial images the bony bump here. Even without drawing the circle and measuring exactly the angles, you can definitely see the bony bump. You can see the high signal in the labrum, the irregularity of the cartilage here, and again the bony bump. Okay, there are already osteoarthritic changes in the joint. Okay, next case. So this is a case where these are coronal T1 weighted images. You see that it's not fat suppressed, and you can see that the signal in the bladder is dark. So it's a T1 weighted image. And these are T2 weighted images. And the major finding here is edema in the left acetabulum. Right? These are coronal images and these are sagittal images. So there's a differential diagnosis to edema in the acetabulum that extends to that involves the articular surface, the subchondral bone. So you could think maybe of osteoarthritis, and you can think maybe of a tumor or metastasis. It's an area with red marrow. It's a pretty common area for mets. But in this case, if you look cautiously, you can see, if I find my arrow again. Oops. The mouse stopped working. The mouse is not working. Okay, so we'll just work with the buttons. I'm sorry I won't be able to point at the... I think you need to call someone because it's not working. Okay, so basically if you look here, and here, and up here, which I can't show you, there's a fracture line. So this is an acetabular stress fracture. Okay. So this is an, can you see it? Can you see the line? I can't point at it. So it's an acetabular stress fracture. So this linear low intensity helps you to reach the diagnosis, to eliminate all of the other differential diagnoses and stay with one. And this is another example of edema in the acetabulum. However, in this case, it's different. because you have edema on both sides of the joint. In the acetabulum, in the femur, you have fluid in the joint. Yeah, but I just can't point at it. Okay, so you can see this pathology. I feel like now I'm on the airplane. I'm going to
So we're the focal. We're the focal. Merci, monsieur.
Okay, so this time it's a pathology involving both sides of the joint. So you could think of what? Arthritis, right? Because it's both sides. Arthritis, what type of arthritis? Any. It could be infectious and it could be other. But then you have another clue. What's the clue? The other side, right? So although it's a fat suppressed image, you can see that there is AVN on the other side. So this is actually a case of AVN that involves the acetabulum as well. When you see this bone marrow edema syndrome, when there's bone marrow edema in the femoral head, and you don't see the AVN, you can think of transient osteoporosis, or today it's even called insufficiency fractures of the femoral head. So what you see is this edema. Sometimes you can see subchondral stress fractures, which are hard to see in this case. The edema really extends distally to the neck, to the base of the neck. And this is a case of transient osteoporosis. Usually there's complete resolution from this osteoporosis, from this bone marrow edema syndrome, insufficiency fracture. But the patient needs to be taken off weight bearing in order not to injure the joint while bearing weight on it when it's osteopenic and edematous. Okay, so what is this case? Is it normal or is it abnormal? Is it a tumor or is it something else? Who votes for a tumor? Who votes for something else? Okay, so that's an easy one because many people voted. So this is a case of a chronic hamstring avulsion injury. Okay, and since the hamstring inserts on the bone, it can mimic a tumor. You can see it looks like a lytic lesion with sclerotic components to it and sclerotic margins, but this is actually more of a sports injury. So this is an MRI of a finger, and you can see a mass, right? It's easy to see it on a non-fat suppressed image because the fat actually serves as a contrast, the anatomical contrast on MRI, and actually every other kind of study. The fat is bright and the pathology is dark, and you can see nicely this tumor. So what is this tumor? On the sagittal images, you can see the flexor tendon, and you can see that the tumor goes along the tendon. Axial images, again, that's the flexor tendon. There's no fat around it. Here you can see some fat around the flexor tendon. There's no fat around it. It looks like it surrounds the flexor tendon. On these images, again, see the enhancement, and it's another example. You see an enhancement. These lesions are very typical for this location. It's called giant cell tumor of the tendon sheath. Has another name. What's the other name? PVNS. But usually in PVNS, when you see it in joints, you really want to see some metal in it, some blood components. You don't have to see these blood components when it's PVNS of the tendon sheath. So you don't have to use gradient echoes for that. Okay, I prefer to go to another case, and not this one. This is a young woman that presented, she's 22, and she presented with left arm swelling. So it's a diffuse left arm swelling up to the shoulder. What would you think of? Maybe she has a venous occlusion, and she was